Morning. I'm very pleased to introduce Dr. Anuka. She's a assistant professor in Department of Medicine. And today she's going to take us through the updated version of the Consort checklist for randomized control studies. She's put a lot of effort into it. And from her previous presentation, I'm sure you'll all learn very well. All the best, Anuka.
Thank you, sir. Good morning. Today we'll be discussing on Consort 2025, which is a new reporting guideline for reporting randomized control trial. So this was published recently on April. So we will be going through the checklist. So the outline for today's talk would be introduction of the Consort 2025 guidelines and using this checklist in RCT. So the Consort 2025 statement was updated. It's an updated guideline for reporting randomized controlled trial. This was published recently in JAMA. So Consort stands for Consolidated Standards of Reporting Trials. So initially published in 1996, revised in 2001, updated in 2010. Then along with the Spirit group, the current updating was done in 2025. So it is a 30-item checklist. They have added new 7 checklist items, revised 3 items, deleted 1 item, and integrated other from the Consort extensions and from the TIDER guidelines. So the item which is deleted was on the section on generalizability of trial finding, that is now incorporated under the last item, which under the heading of limitations. So this is how the checklist looks like. We will go through it in detail. It has 3 sections. One is on the section and topics. Other is the item. There are around 30 items, and each item has a description on what has to be reported. They have also given the Consort figure, flow diagram, and how to show the Consort figure. Now coming to the case for today, this is Mr. N, 50-year-old man with multiple comorbidities, with a previous stroke, diabetes, hypertension, had a previous GI bleed, and has 1 year ago had a MI for which he required a stent. He underwent something called a PTCA stenting. Following which, based on the guideline, he needs to be on 2 dual antiplatelets, aspirin and clopidogrel. After 1 year of completing double antiplatelet, based on the guideline, he needs to be on single antiplatelet. So he's on aspirin and clopidogrel. Now, for the current single antiplatelet, which one would you choose, aspirin or clopidogrel? So to answer this question, we will be looking at this article, which looks at safety and efficacy of clopidogrel versus aspirin monotherapy in patients at high risk for subsequent cardiovascular event after a percutaneous coronary intervention. This was a Smart Choice 3 trial, which was published in Lancet. So this was published in April 12. The guidelines have actually come after that, but we'll be looking there to see how it fits in the checklist. So going through the checklist, the first section is on title and abstract. Is there a title and a structured abstract? The first is on identification as a randomized trial in the title. So this is how the title looks like. Title is on efficacy and safety of clopidogrel versus aspirin, and they have given that it's a randomized open label multi-center trial. Second is structural summary. So this is how the summary looks like. So they have given section on methods, finding, and conclusion. Trial, second section is on open science, trial registration. So name of the registry, identifying number with the date of registration. So this is taken from the study. They have given the trial registration number. They have given that is ongoing and expected to continue for 5 years. But the date of registration is not mentioned in the study. Protocol and statistical analysis plan. Where can it be added? That is item number 3. So they have given actually, they have provided they have actually down the text is that they provided where it is given. And if you go to the appendix, they have actually given the protocol and the analysis plan. Item 4 on data sharing. Now, the individual participant data or the code, anything, or the material, where can it be accessed? To the end, they have given a session on data sharing. They have written that the data collected will not be publicly available, but will be shared upon request for collaboration, and it has to be, inquiry has to be made to the corresponding author. Fundings and conflict of result. So the source of funding, they have mentioned the source of funding. They have mentioned the role of the funding source, and they have also mentioned the declaration of interest. So this is actually well reported. Coming to the next section, which is on introduction, background and rationale. So this is how the introduction starts. They start with the scientific background. They have given a good rationale and why they have chosen this study. And the rationale they have given is, so after a DAPT, the previous standard practice was the aspirin monotherapy. That was based on a meta-analysis. 2024 European guidelines has given probable clopidogrel is superior based on a trial. Now, this study is to look at what is the role of clopidogrel versus aspirin in a high-risk profile patient. Next session is on objective, that is item number 7. They have clearly stated their objective to look at efficacy and safety of clopidogrel versus aspirin in a patient with high risk of recurrent ischemic events. The next session is on methods from item 18, 8 to 16. Is on methods. So we will go through each of that. First in the method is, was the patient and public involvement reported? So actually in this study, they have not mentioned if they were involved in the trial or the conduct of the study. Item 9 was on trial design, description of the trial. So they have mentioned it's a randomized, prospective, open label, multicentric, parallel group trial with the allocation of 1:1. Changes to the trial protocol, was any changes made after it has started? So they don't have any explicit mention of any post commencement changes. Trial setting, is it a hospital-based setting or what is the location? So it was conducted in South Korea, 26 center. It is a hospital-based study. Eligibility criteria. So 12A is on eligibility criteria for participant. 12B is for criteria for the center or the individual during the studies. The institutions are listed, 26 centers. There are no specific criteria for them. Eligibility criteria they have given quite well for the participants. So we'll go through the inclusion criteria.
They give all this as subheadings, or you have to search and find out in the text?
So most of them was there in the text. The initial thing, it was there in the text. So under the text of methods and recruitment, they have given this. So this actually I have taken from the supplementary. It's given as a word in the text, but in the supplementary they have given as a points. So they have 4 inclusion criteria: age more than 90. So they should actually be eligible. So they should have undergone a PCI. Should have using a drug eluting stent. They should have received standard duration of DAPT, which they defined as post-MI for 1 year, and for chronic coronary 6 months. And they should be able to understand risk and benefit and should give signed informed consent. So they have taken patient with high risk of recurrent ischemic events. They have defined high risk as clinical versus complex coronary angiographic characteristics. So clinical characteristics are the patient with prior MI or patient with diabetes on medication. Complex lesion are the complex coronary. So this is they have given a clear definition how the angiographic, what is called as a complex coronary. So this was the inclusion criteria. This was the exclusion criteria. Patient with hypersensitivity, patient who required other therapy, anticoagulation, who required DAPT, or patient who are scheduled for a revascularization, so they will be actually requiring DAPT. Patient who are already taking antiplatelet screening, pregnant or lactating women. And the last one was as per investigator medical judgment. So this was a short exclusion criteria, can be adaptable for generalizability. But I think only apart from the last, which is little ambiguous, others were quite reasonable. Intervention and comparator. Have they mentioned the intervention and the comparator? So intervention now was clopidogrel 75 mg, aspirin was 100 mg daily. That was a control arm. Outcomes. So pre-specified primary and secondary outcomes. So they have actually mentioned it very adequately. So they had looked at the major adverse cardiac and cerebrovascular events, MACE at 1 year. That was a primary outcome. And they had actually 19 secondary outcomes. So MACE is composite death from any cause, MI or stroke. So secondary outcome, they had 19 secondary outcomes they are planning for. Harms. How were the harms identified and assessed? So the bleeding events were characterized as per the BRC definition. So this is the definition. Type 1 is a non-significant bleed and type 2 to 5. So higher the type, the severe the bleed. So this is actually the guideline for any cardiovascular study. So this is what they have used to look at harm. Sample size. So how sample size was determined? Assumptions and the assumptions supporting the sample size calculation. So they have given how they have calculated sample size. They had so aspirin, the aspirin group, they had expected a 4%. They had looked for a 25% relative reduction. So that is 3% in clopidogrel arm with a two-sided alpha of 5%, beta of 18%, that is power of 82%. With a dropout rate of 2.5, their calculation was 5,000 total with 2,500 in each arm. So this is they have actually given in test how they have calculated the sample size. Was there any explanation of an interim analysis or stoppage guideline? There was no interim analysis plan, but for the sample size, this is what they had reported. So they had reached 5,000. They had planned a 3 year of approval, recruiting 3 years. They had crossed sample size of 5,000. Subsequently, a blind analysis of the data set was done without any previously planned interim analysis. And they found that the event rate was actually lower. And they have actually planned to continue more recruitment till the 3 year period. And they have justified that this is based on the principle given in International Council for Randomization. The next session is on randomization. That is item 17 to item 21. So sequence generation, who generated the random allocation sequence and the method used. So they have used this web-based randomization process. It was on 26 centers. So they have used a centralized web-based randomization. Computer-generated block randomization, block size of 4, 1:1 ratio with the stratification based on the index PCI and the centers. Allocation concealment. So what is the mechanism used to implement random allocation sequence? So this is not clearly mentioned. Actually, in the supplementary or in the main text, they have not mentioned if they have concealed allocation. Implementation, how was it allocated, or whether people who were allocating was it concealed? That is also not mentioned in the text. Blinding. So the allocation is not mentioned, but since it is centralized web-based randomization, we can assume it probably would have been concealed. So blinding. So this was an open label study. The participants, the investigator, and the treating physician were not blinded. The outcome assessors were blinded, but the primary outcome was mortality, which is a very hard outcome at end of 1 year. So that may not have changed, but a lot of co-interventions might be different, which might have little bit affected the study. Statistical methods, what method they use to compare group of primary and secondary outcomes. So they have looked at hazard ratios and 95% confidence interval. Definition of who is included in each analysis. So they have done both the intention to treat analysis and a per protocol sensitivity analysis, and they have given the detailed participant numbers. They have provided the detailed numbers. How missing data was handled in the analysis. This is actually given in the test. They have said that the data from the patient who didn't have a primary endpoint were censored, either at the last known contact or at 3 years. They have also given in the supplementary how they have used the missing values. So for the baseline variables which are missing, no imputation method will be used. But for the endpoint or the outcomes, for patient lost to follow up, the data was censored. Item 21, method for any additional analysis which is planned. So they have planned a subgroup and a sensitivity analysis for a per protocol analysis. They have also done an exploratory analysis. So we know that clopidogrel is a prodrug, and then the body has to be metabolized to the active drug by an enzyme called CYP2C19. Because of the genetic polymorphism, some people might be slow metabolizer. So the level of the drug might be less. Some will be normal. So they are called the rapid metabolizer. So because of the genetic variation, they had decided to do a genotype testing in the patient in the clopidogrel monotherapy arm. So this also they had planned and they have done it. They have also mentioned that they're planning to publish a cost economic analysis subsequently. The next session is on results. So participant flow, including a flow diagram. So this is a flow diagram. So they had screened 5,542 patients, 36 were excluded, 5,506 were randomly assigned to the intervention arm and the experimental arm. They had 30 who didn't complete 1 year follow-up. The data was missing. 1% follow-up in the intention to treat arm. They have included everyone in the intention to treat analysis. The per protocol analysis, people who fully adhered to the per protocol was 2026. So this is how they define per protocol. The people who have not violated the protocol, that is, there is no interruption of the antiplatelet, or they've got DAPT, or antiplatelet is not used, or there's some crossover in the study, or they have used another antiplatelet or another dose. So this is what they have put as protocol violations, and they have given how many people who had no violation and how many people who didn't fully adhere to the protocol, either by getting some other device or judgment by the clinician or by the patient, or some prescription errors. So coming to the consort figure, so looking at the intention to treat, they had 1% follow-up, loss of follow-up. In the per protocol, around 5% data was missing in the chart. Recruitment, so date defining the periods of recruitment and follow-up for the outcomes of benefit and harm. If there was a trial stopped early, trial was not stopped early. They have clearly given the dates and the median follow-up was 2.3 years. Intervention and comparative delivery. So this was a self-administered tablet. There's no other mode of delivery required. So this is probably not really applicable. Concomitant care received during trial in each group. So this is, so they had a 6-month follow-up, 1 year follow-up and yearly follow-up thereafter. Primary outcome was after 1 year. So this is a 6-month visit. So some people, there was some mortality. And this was the data on the people who had medication use. And mainly if you look at the antacids, it's little high in the aspirin as compared to the clopidogrel group. I mean, around a 2% difference is there. When we go at 2 months, there is some, the 2% difference is maintained. But if you look at the aspirin and clopidogrel group, there is some crossover. Around 2% they have. This is the clopidogrel group, around 2% has taken aspirin. So this is subsequent visits. This crossover is little bit increased and around 4% more antacids in the aspirin group. So baseline characteristics. So they have given a table for baseline characteristics. Actually fairly well matched, more male population. Only 1% difference in the CKD group, which is more in the aspirin arm. So that would be arm at a disadvantage. Similarly, bleeding risk was little more by 1%. 1% in the aspirin group, they are at a disadvantage. And probably because of that, little bit of antacid is more in the aspirin group. Otherwise, the baseline characteristics is very much. Numbers analyzed, outcomes and estimation. So this was the primary and the secondary outcome, the result. So they had looked at MACCE, major adverse cardiac and cerebrovascular events. So the events were 92 in the intervention arm versus 128, 4.4 to 6.6. Hazard ratio of 0.71, so around 29% reduction with a good confidence interval on one side. So absolute risk reduction was 2.2, and with that we can calculate the number needed to treat, which comes around 45. So this was the primary endpoint. This was a secondary endpoint. So they had actually a lot of secondary endpoints, and they have mentioned that they have not put the p-value because they have so many. Among this, only the MI was significant. Nothing else was significant. So this is a survival curve. So you can see that in the axis, y-axis, they have actually not taken from 0 to 100. They had a 2.2 difference. So they have actually put from 0 to 10 and then they have shown that. So they have kind of enlarged the curve. So there is a mild separation, mild difference. In the depth, the curves are actually crossing each other. You have to be careful interpreting the result. Others two were quite similar. This was a per protocol analysis. People were adhered fully to the protocol. This was also similar, absolute reduction of 2.3%. This is a survival curve for them. Harms. How do they report the harms? So all the harms are unintended events. So they had looked at the BRC classification. This is all the bleeding, type 2, 3, 4, and this is the major bleeding. So all the bleeding is not actually significant. But if you look at major bleeding at the end of 3 years, clopidogrel group had 1.6%, aspirin group had 1.3%. That's a 0.3 difference, but it's not statistically significant because the confidence interval is crossing. But just for learning purpose, if you take a 0.3 difference, we can actually calculate a number related to harm. 100 by 0.3 will come to approximate 333 patients. That would be the number related to harm if this was significant. So this is how they have reported the harm. They have similar figure for a per protocol analysis. Ancillary analysis, other analysis which they perform, they've done a subgroup analysis, which was not significant. They have done a competing risk analysis because there are multiple outcomes. So they have done a competing risk analysis. They have done a subgroup analysis for major bleeding. And they have also given in the supplementary for significant bleeding, landmark analysis for primary endpoint subgroup analysis. So they had also done a clopidogrel genotype. The genotyping to look at fast responders and normal slow metabolizer. So they have given a cumulative incidence for them, which was actually quite similar in both the groups. So both the rapid or the poor were quite similar. Last item 29 and 30 is on discussion. So this is their discussion. Actually, it starts with their results, and they have talked about interpreted the results compared with the existing evidence. They have given a biological explanation. They have discussed benefit and harm, which was very well reported. And they have limitation. They have discussed what the bias. They have acknowledged the lack of diversity. It was everything was South Korean population and limits in generalizability. So this is the Consort 2025 checklist. They have actually reported quite well. Few areas they have not explicitly mentioned is the allocation and patient and public enrollment. Otherwise, it was a very well reported study. Now coming to the external validity. So this was a study well done. We showed a 2.2% absolute risk reduction. How will it help us locally? Can this study be applied, results be applied to your local population? I'll just come to each one. Are the participants similar to the patient in your care? Yes, elderly male with comorbidities, with cardiovascular outcomes. We have similar population. We have similar study participant. Is there a difference in the population? This is from the World Heart Report. So they have actually clubbed Southeast Asia where we are with East Asia where Korea is, and they have actually clubbed it together. But if you look at the regional wise distribution, this is where India is. India, and this is North Korea, this is South Korea. So you can see that actually they have quite less incidence of cardiovascular compared to India. So we actually have more incidence. So probably our outcomes might be, here it might be even better. Is there polymorphism? So this is a study which looked at polymorphism Indian patients. They found that North Indians have slightly more compared to South Indians, but it was actually comparable to the Caucasian population. And South Korea, the study they have mentioned that they have higher range of poor metabolizers compared to Caucasian. So we might be quite similar to that population. Are the outcomes important to a population? Yes, the outcomes are important. Are there any other outcome we wanted information on? So one is cost, which is not reported. So if you look at for 1 year, clopidogrel 75 comes to rupees around 7 rupees. So 1 year will come to 2,555. Ecostrel will come to around if you make it 0.4, it comes to around 1 year of 131 for a year. So around excess of 2,500. This is a yearly cost difference. Are there any other limitations that would affect? So one is open label of nature. So that would have been quite co-intervention, probably lifestyle interventions or antacid which can reduce the harm, and some loss of follow-up. So looking at this is the consort figure. So we don't have data for the 30 and 32 patients. So if you do a best and worst case scenario, the total events, total people, total event, and these are the data we don't have. In a worst case scenario, if we assume all of them did bad, then the best case is what they have done. If all of them did bad, then if you do that, it comes to a relative risk of 0.95 with a confidence interval, which just an assumption is. Coming to the second question, would it provide greater value to the people? So if you look at the overall cost from a provider perspective, so in this study, if we take number needed to treat was 45, and if we suppose number needed to harm is 300, and if you take clopidogrel rupees 7 and ecosprin 0.5 rupees, so the yearly cost to gain 1 MSCC would be 365 into number needed to treat into 7 rupees, that will come to around 1,14,000. That would be this much amount is taken to get 1 MSCC. Similarly, for aspirin would be 8,000. So this would be the extra around 1 lakh. This is to gain 1 MSCC. But if you want to include harm in that, that means if you treat 300 patients, you will have 1 harm and you will have 6 benefits. And it is 45. So if you include that, so to save 6 lives, and if you get 1 benefit, the cost will come to around 7.6 lakhs. And if you approximate, if suppose the cost of treating 1 major benefit, bleeding is around 1 lakh, the total cost would be around 8.6 lakh. This is from the provider perspective. And ecosprin similarly would be 1 lakh 54,000. This is from the provider perspective, the overall cost. So this would be the resources needed. Probably reasonable compared to the other interventions which are more costly. So with this, we have completed the external validity. So coming to our patient, what anticipated would you choose? Leave it open for